Hey guys, so this is the next installment of the pathology series, and we're going to be talking about normocytic anemia of the extravascular and intravascular kind. So, as we know, anemia is just a decrease in the number of circulating red blood cells. So, we know that red blood cells have a compound called hemoglobin, which carries oxygen and it binds to oxygen. It carries the oxygen from the lungs to the tissues, and it is the primary mode of transport for oxygen. Now, in anemia, since there's a decrease in the number of circulating RBCs, that means that the oxygen carrying capacity of the blood decreases, and this is what we call hypoxia. The symptoms of hypoxia are then in turn the symptoms of anemia. The non-specific symptoms include fatigue, dyspnea, and pallor, dyspnea being shortness of breath. Pallor, obviously pale skin. More specific symptoms like pale conjunctiva, cold skin, lightheadedness, and angina. Angina refers to chest pain, and this is most likely because of a patient that already has coronary artery disease and then is precipitated by symptoms of anemia. Lightheadedness, on the other hand, is just decrease in blood flow to the brain, and so the patient presents with symptoms of some of the signs that a patient with anemia would present with are tachycardia, which is an increase in the heart rate. And this usually happens as a compensatory mechanism for the decreased oxygen carrying capacity of the blood. Glossitis, which is inflammation of the tongue leading to swelling of the tongue. And this can be seen specifically with B12 and folate deficiency. Koilonychia, which is a kind of deformity of the nail that comes with iron deficiency, and dark urine, which can come with most anemias really, but it's basically because of increased red blood cell components in the urine as a result of increased hemolysis. We will talk about that soon anyway. And the approach, obviously, you take history and present problems of the patient, and if and it's because of the prevalence of anemia as well, it's very likely that we consider this on the differential physical exam. Remember to take the neurovascular exam as well as the cardiovascular exam to make sure that there's no permanent deficits in these areas, because they are the most sensitive areas to oxygen deficiency. So neurovascular and cardiovascular. And then you have to take a blood test, which is obviously very important for the diagnosis. In the blood test, we do CBC, or the total blood count, in which we consider values of hematocrit, hemoglobin, as well as RBC count. Hematocrit is basically just indicative of the ratio of the volume of red blood cells to the volume of the plasma. It's very important to consider that this is in fact a ratio of the two of them, because if you were to lose a large volume of blood, you would lose equal parts red blood cells and plasma, and therefore the hematocrit would be normal. But the fact that you lost RBC would not be indicated in the hematocrit, and that's quite important to consider when you're looking at the hematocrit. Hemoglobin also is hemoglobin on the other hand is an absolute value, so using it to define anemia would be more accurate, and that's why we define anemia as a hemoglobin less than 13.5 gram per deciliter in males and less than 12.5 gram per deciliter in females. The threshold for females being lower because of menstruation and loss of blood. Then we do mean corpuscular volume, which is a very absolute value for the volume or the shape and the size of the red blood cell. So if it's microcytic, it's less than 80 nanometer cube. Normocytic is 80 to 100 nanometer cube, and macrocytic is greater than 100 nanometer cube. And obviously, the normal size is 80 to 100. And next we can do a blood smear. And blood smear is also very important because there's some specific cells that we will see in the following sections. They're important to consider when you're diagnosing a patient with a kind of anemia. Right. So the range of symptoms depends on the severity and the patient's tolerance, which is to say that if a patient has a good compensatory mechanism because they're younger, they have a better cardiovascular health, then it's more likely that even higher changes or large drops in the hemoglobin would be compensated pretty fine, and the patient may be even asymptomatic. But on the other hand, if the patient is older, they have COPD, and they have other cardiovascular or respiratory deficiencies, even a slight change in hemoglobin can precipitate with symptoms. So it's very subjective, the symptom presentation. But just as a rule of thumb, it's important to keep it stable in mind. Anything greater than 10 and 30, you would be asymptomatic. The patient would be just fine. 8 to 9, tired, fatigue, malaise, very non-specific symptoms. 6 to 8, you'd see dyspnea and exertion, which is to say that the patient would be short of breath when they start to exercise. 4 to 6, you'd have symptoms of decreased hypoxia of the brain, and this would be lightheadedness, presyncope, and syncope. And again, syncope and presyncope just refer to the patient fainting and the symptoms before they faint, essentially, which could be lightheadedness. And then, obviously, if it's less than 4, it would be very acute, and you'd have chest pain or angina, stroke, and high output failure. So, when you look at the patient, this is just the approach to the patient, I suppose. So you look at the symptoms of the patient. They could have fatigue, malaise, shortness of breath, pallor, pale conjunctiva, etc., etc. In that case, you would do the CBC. And if the hematocrit in the hemoglobin is normal, then it's something else. And you'd look at maybe a cardiovascular defect or respiratory problem. But if it is decreased, then it's definitely anemia. And your next step would be to do the MCV to find out what kind of anemia it is. Right. So in the previous sections, we spoke about microcytic and macrocytic anemia, and now we're going to be talking about normocytic. Normocytic anemia means that there's a decrease in the blood volume of the RBCs, but there's also the RBCs that are being produced are of a normal size, that is to say 80 to 100 nanometer cube. So normocytic anemia can then be divided into hemolytic or non-hemolytic. Hemolytic just means that the RBCs are being produced just fine, but for some reason there's an increased destruction of RBCs outside of the site of production. This can either happen intravascularly or extravascularly. On the other hand, non-hemolytic just means that the bone marrow isn't able to produce RBCs, and so therefore there's a defective RBC production. So, coming to the basic principles of normocytic anemia, like I said, the mean corpuscular volume is 80 to 100 nanometer cube. The etiology, again, could be hemolytic or increased peripheral destruction, and non-hemolytic or underproduction anemia. Different books and different sources will call it different names, but this is, if you just remember the word hemolytic and the fact that there is destruction of the RBCs, you already know that the bone marrow is just fine, so this would be a problem with increased peripheral destruction. On the other hand, non-hemolytic, which is to say that it's not, the RBCs are not being destroyed outside, they're just defective when they're being made, would obviously mean that that's an underproduction kind of anemia. And again, when you think about hemolytic, you want to ask yourself, where is the RBC breaking? Or where is it being lysed? Is it inside the blood vessels or is it outside? Now, why we use the words predominantly is because most anemias are usually a combination of both intravascular and extravascular. It's very rare for you to have just an intravascular or extravascular. So it's considering these, it's important that you go ahead, because sometimes you'll see signs of extravascular hemolysis in anemia that is considered intravascular, and so you just shouldn't be confused. And how do you diagnose a person with normocytic anemia? So again, this is, I guess, the approach. When you look at the CBC, you discover that it's anemia, and then you do the MCV, find out it's normocytic. And then you can then consider if you had a problem with bleeding, which would then be acute blood loss, or if there was destruction of the red blood cells inside or outside the vessels. And for that, we have something called reticulocyte count. Reticulocyte count is basically the number of reticulocytes that you have inside in a blood smear. And the reticulocytes are basically just young red blood cells. They're immature. They still have some amount of nuclear material in them. And we know that RBCs, mature RBCs, have no amount of nuclear material in them. So reticulocytes can be distinguished from a regular red blood cell in a blood smear. I'll show you pictures soon. But what you need to remember is that they are larger cells and they have a bluish cytoplasm. And this is because of the presence of RNA still present inside the cell. So a normal reticulocyte count is 1 to 2%. And we can go as far as to say, let's say 3%, especially in the corrected count, which we'll talk about soon. But yeah, 1 to 2% is normal reticulocyte count. So that is to say, for every 100 red blood cells that you see inside the blood smear, 98 of them are mature, 2 of them, or 1 to 2 of them, are reticulocytes. And that's completely normal. And this is actually important to show you your bone marrow response. If you were to have fewer RBCs, your bone marrow would decide to produce more. And when you have something called a left shift, which we'll talk about soon. So this is how a regular or the production of a red blood cell looks like. So initially you have large proerythroblasts, and these ones have a large amount of nuclear and cytoplasmic ratio, which is to say that the nucleus is nuclear to cytoplasm. The ratio is, it starts off pretty high because the nucleus is pretty massive. But as you go lower down and as you make a mature red blood cell, the size of the nucleus drastically reduces and then eventually disappears. So the ratio, therefore, decreases as you go along this way. And this is very important to consider because inside the blood, you should be able to see more number of red blood cells to reticulocytes. But when there is an acute deficiency of red blood cells and your bone marrow decides to produce a large number of red blood cells, the number of reticulocytes inside the blood would increase. And this is what we call a left shift, because you see that there is an increase in the number of immature red blood cells inside the blood. But of course, this is completely physiological, and in fact, this is preferred because that means that your bone marrow is responding really well to a deficiency of red blood cells. This is what a reticulocyte looks like. As you can see, they are significantly larger than a red blood cell, and they definitely have some amount of bluish substances in their cytoplasm, and this obviously is RNA. And this is just a diagram, so obviously it's much larger as well. Going back, so a normal reticulocyte is 1 to 2%, but what we need to also consider is that reticulocyte count, again, is relative. If there's an increase or decrease in RBCs that isn't related to anemia itself, then your reticulocyte count could be false, or it could be a false indication of a disorder. That's why it's important to correct the reticulocyte count, and we do so by multiplying the reticulocyte count by hematocrit divided by the normal hematocrit of blood, which is about 45. So that's important to consider as well, because we always try to deal with absolute values. If we're using relative values, we need to correct it, because again, the increase and decrease of red blood cells in plasma is variable. The etiology cannot just be about anemia, and when we're trying to diagnose anemias, it's important to do that. So when the corrected count is greater than 3%, it indicates that there's a good bone marrow response, and therefore it is hemolytic, or there is peripheral destruction. Corrected reticulocytes less than 3% indicates that there's a poor bone marrow response, and that suggests underproduction or non-hemolytic. Yes. So let's talk about hemolysis first. And as we discussed earlier, it can be divided into extravascular and intravascular hemolysis. When you ask yourself, where is the hemolysis happening? The answer to that could be extravascular or intravascular. So both of them result in anemia, and the bone marrow response is good, as we discussed earlier, because there's no problem with the bone marrow itself. The problem is with peripheral destruction of the red blood cells. So let's talk about extravascular hemolysis first. What we're going to do right now is, this is how it's done in Pathoma as well. We're going to divide it into extravascular and intravascular, talk about the etiology and the pathophysiology of each kind, and then we're going to talk about the individual disorders. In that way, we can classify the symptoms together, understand why that happens, and then we can talk about the diseases themselves. So extravascular hemolysis is basically when the RBC is flowing through the blood and then it reaches the reticuloendothelial system, or the spleen, liver, and the lymph nodes. And we know that the reticuloendothelial system is basically just a meshwork. And what happens is your red blood cell will go through that meshwork and it will be broken down. And when it's broken down, you have a molecule called hemoglobin, right? So most of the RBC is basically just hemoglobin with some amount of cytoplasm and membrane. And so the cytoplasm and membrane just being proteins mostly will just disintegrate. But hemoglobin is the molecule that has heme and globin. Heme is basically just iron and protoporphyrin. So when we talk about the disintegration of the RBC, we also have to consider what happens to the hemoglobin. So the hemoglobin breaks down to hemoglobin, iron, protoporphyrin, and then your globin is basically just amino acids. So then that would just break down on its own. But the heme has iron, and iron cannot just be iron basically will get recycled. So it can't just be excreted, so it gets recycled. And the protoporphyrin, on the other hand, this is what needs to be excreted, and this is where the problems arise. Protoporphyrin is, basically it becomes unconjugated bilirubin, and because unconjugated bilirubin is insoluble in blood, it binds to albumin. And both of them reach the liver, and then in the liver it is conjugated from unconjugated bilirubin to bilirubin, and then eventually the bilirubin is excreted via bile. So what can you find clinically? So obviously, when there's an increase in hemoglobin, there's an increase in heme, there's an increase in protoporphyrin, there's an increase in iron. And the increase in protoporphyrin would mean that there is an increase in unconjugated bilirubin. And the problem with that is that the liver has a limited capacity for conjugation, which means that there's only so many molecules of unconjugated bilirubin that the liver can conjugate, and the rest of the unconjugated bilirubin, which is now bound to the albumin, will rise in the blood. And when it does so, we get something called jaundice. So the patient with extravascular hemolysis will obviously present with symptoms of anemia, with symptoms of jaundice, and also because there's an increased amount of conjugated bilirubin, it goes to form a dark urine, and increased unconjugated bilirubin in the blood will cause precipitation in the gallbladder, causing gallbladder stones. And because the reticuloendothelial system is now activated and it's highly reactive, you'd have a reactive hepatosplenomegaly, which is just an increased size in the liver and the spleen, and a marrow hyperplasia, obviously, because now your bone marrow is working hard to replace the number of RBCs that are lost. And the questions that we answer in the next few sections is, why is there a breakage of the RBC in the reticuloendothelial system? So what defect does the RBC have such that it's being taken down by the reticuloendothelial system? So here's a diagram to just describe it. So you have hemoglobin, and hemoglobin breaks down into heme and globin. Globin just becomes amino acids and is taken up and recycled. Heme, on the other hand, as you know, is iron and protoporphyrin. Iron gets recycled. Protoporphyrin converts to unconjugated or bilirubin. It binds to albumin, and is taken up to the liver, where it is conjugated to bilirubin, excreted through the bile, and the bilirubin is then, excreted. The unconjugated bilirubin would go back to the blood, and it would cause jaundice, the increased amount of bilirubin would precipitate in the gallbladder and cause gallstones, and also would cause a darker urine because of the increased amount of urobilin. And now we talk about intravascular hemolysis, and that involves destruction of red blood cells within the vessels. So what that means is that within your vessels, you now have a high amount of hemoglobin. And hemoglobin binds to a free molecule that's just kind of flowing around in the blood called haptoglobin. And hemoglobin will then go to bind the haptoglobin, and that's the only way it can exist in the blood. So what that means is that the amount of free haptoglobin that you have left in the blood would decrease, and that is a sign of intravascular hemolysis. So obviously anemia and decreased serum haptoglobin. Now, hemoglobin has to be excreted via the kidneys, and this causes a number of problems. Obviously, the amount of hemoglobin that's leaving the body would increase, so you have hemoglobinuria and hemoglobinemia, which is a deficiency of hemoglobin. But another problem that happens is, again, we know that hemoglobin breaks down into heme, which is iron and protoporphyrin, and globin. And so when there's iron in the tubules of the kidney, it enters the tubular cells, causes oxidative stress because of free radical and oxygen release, and therefore it causes the cell to die, slough off, and be excreted in the urine. And this is called hemosideruria and dark urine. And that's why you have dark urine. So now we know the way that extravascular and intravascular hemolysis present themselves in an anemic patient. Again, just to reiterate, you have hemolytic and non-hemolytic, increased amount of reticulocyte count, decreased amount of reticulocyte count because of a defective bone marrow. And again, hemolytic can be, again, we discussed the intravascular and extravascular, but we can also discuss intrinsic and extrinsic, and that's where we have the following diseases that we discuss about. So if you have an RBC defect, it could be hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria. You can have enzyme deficiencies like glucose 6-phosphate deficiency, pyruvate kinase deficiency, hemoglobin abnormalities like sickle cell anemia. And extrinsic is just that the RBCs are normal, but because of some antibodies or defective mechanism with the reticular endothelial system, you'd have an increased amount of hemolysis. Keeping all of this in mind, we've officially divided normocytic anemia into hemolytic, non-hemolytic, and we've divided hemolytic into extravascular and intravascular. And additionally, you can also divide it as intrinsic, which is to say that there's a problem with the RBC, and extrinsic, which is to say that there's a problem not within the RBC, but somewhere, some other system, maybe the immune system or the reticular endothelial system. And keeping all of this in mind, we can now move on. So let's start off with normocytic anemia with predominant extravascular hemolysis. You have hereditary spherocytosis, sickle cell anemia, and hemoglobin C. And now onto hereditary spherocytosis. So usually the red blood cell has a discoid shape, and the discoid shape is provided to it by its cytoskeleton. Now the cytoskeleton is bound to the membrane by these proteins, these anchoring proteins called ankyrin, spectrin, or band 3.1. And what this means is that because of this unique shape, the membrane has the ability to be very flexible, and therefore the RBC can withstand a lot of different stresses, which include putting it, if at all it has any osmolar changes in the blood, the extra membrane would allow for it to change its shape and be just all right. And on the other hand, it can also kind of pass through and maneuver through the reticular endothelial system and not be phagocytosed by the macrophages, or broken down by the meshwork inside the reticular endothelial system. So what happens in people with this disorder is that this protein is messed up. It's problematic, which means that the membrane is not as strong as it used to be. As a result, you have these defective red blood cells which have blebs on their membrane. And these blebs are taken off by the macrophages as it passes through the spleen, and eventually you'd lose more and more of the membrane, rendering the older RBCs spherical. This means that the unique ability of the red blood cell to be flexible is not present anymore. And so when this passes through the meshwork of the reticuloendothelial system, it is lysed. And therefore you have symptoms of extravascular hemolysis. So looking at the clinical symptoms, like we mentioned, we have signs of anemia with signs of extravascular hemolysis, which include jaundice, hepatosplenomegaly, biliary, increased risk for biliary gallstones, etc., etc. And on the smear, you should be able to see a lot of spherocytes with loss of central pallor, and that's just because of the loss of the membrane. And additionally, you'd be able to see two important things. The first one is increased RDW, which is red blood cell distribution width, and increased MCSHC, which is mean corpuscular hemoglobin concentration. The reason for the RDW is basically that if you were to look at any given blood smear, you would be able to see the younger red blood cells which have their normal integrity and the older ones which also have spherocytes. As a result, you have a wide range of shape and size of the RBCs, which means that you have a larger range of distribution of and also the width of this distribution will be higher. On the other hand, what happens with the concentration of the hemoglobin is that as the cell loses its ability to be discoid and it also reduces in size, the amount of hemoglobin inside the concentration would therefore increase. And lastly, we have something called aplastic crisis, which is basically a disorder that happens when the patient with hereditary spherocytosis has a parvovirus B19 infection. And usually what happens in this disorder is that you'd have the bone marrow have a increase in the number of cells that's being produced in order to combat the disease. But because of the limited reserves of the bone marrow, you'd have decreased bone marrow reserves because of the increased number of red blood cells that it's chronically producing because of erythroid hyperplasia. You'd have something called aplastic crisis, which is the decrease in the non-RBC cells of the bone marrow. So the diagnosis for this would be a very simple osmotic fragility test. So you would basically put the patient's blood in a solution, a hypertonic solution. So a normal RBC would basically have a lot of water go into it, and then it just kind of becomes spherical because it's able to change its shape because of the extra membrane. On the other hand, the spherocytes will just end up taking up the water, and then because of the lack of flexibility, they burst and they lyse. And this is a clear telltale sign of hereditary spherocytosis. Finally, the treatment is to, obviously we can't treat the underlying hereditary disorder, so it's just easier to take off the spleen, and therefore when you take away the macrophages, the RBCs aren't susceptible to become spherocytes anymore. But when you do that, you have something called Howell-Jolly bodies. So this means that basically the RBCs, when they eventually, as they get through the reticulocyte phase and into RBCs, they have decrease in the amount of nuclear material, and sometimes some of the cells escape the bone marrow with some amount of nuclear material. So job of the spleen to kind of take this nuclear material away. But when the spleen isn't present, you'd have some amount of cells with some amount of nuclear material on the inside, and those are Howell-Jolly bodies. It's not a diagnostic measure, but it's definitely something that can be seen on the smear after splenectomy. Next, we talk about sickle cell anemia. Sickle cell anemia is an autosomal recessive mutation in the beta chain of hemoglobin. We know that hemoglobin, basically the adult hemoglobin, for example, is basically alpha 2 beta 2. It has two beta molecules, and these are basically produced by the beta chains, and of which we have two in our chromosomes. So the autosomal recessive mutation in the beta chain of hemoglobin, where the glutamic acid is replaced by valine, would basically result in the production of defective beta globulin. So as a result, you'd have, so if this is the if in the patient you have both the beta chains being disrupted, so the beta 2 that they produce is therefore sickled of the sickle cell kind, and then once they bind to the alpha 2, we have the production of hemoglobin S. And in these patients with proper sickle cell anemia, we will talk about sickle cell trait later, but in this case, there's a chain in both the chains. So as a result, you have complete or 100% hemoglobin S. Again, this will make more sense when we talk about it later about sickle cell trait. So the epidemiology is that it's most likely present in the African population. It's said to be protective against falciparum, so it might be an evolutionary change. And we know that the abnormal hemoglobin is hemoglobin S. Now, what's the problem with this? Basically, hemoglobin S, when it's deoxygenated, it polymerizes. And when it polymerizes, it forms a needle-like structure, which then causes the RBC to become sickle-shaped. And these sickle-shaped cells are more likely to be taken away by the macrophages in the spleen, and B, the membrane over time gets weaker and weaker. Now, we know that basically it's a reversible process. It's just a polymerization. It's not the formation of a covalent bond. It's reversible. So when it's deoxygenated, it polymerizes. When it's oxygenated, it goes back to normal. Now, because of that, because of the constant sickling and decycling, the membrane would just have damages, and over time you would have the increased risk of extravascular hemolysis as well as intravascular hemolysis, and as a result you'd have a massive erythroid hyperplasia. These three things are important to keep in mind because this makes a lot of sense for the clinical findings. Another thing that can happen over a long period of time is that you'd basically just have irreversible sickling. In that case, you have a vasoocclusion, which is basically just end-organ infarction. And the last key point to remember is that hemoglobin F, or fetal hemoglobin, is protective. And this is important for two reasons. First thing is, in sickle cell anemia, the patient will not present with any problems until 6 months of age, because until then you have hemoglobin F, which, like we said, is protective. On the other hand, you also use hydroxyurea as the treatment mechanism for sickle cell anemia. And this is again important because this increases the amount of hemoglobin F in the body, therefore protecting the cells from sickling. So what are the clinical signs of hemolysis, right? So you have obviously the extravascular symptoms like we discussed, jaundice, hepatosplenomegaly, etc. Intravascular symptoms like decreased serum haptoglobin, hemoglobinemia, hemoglobinuria, hemosideronuria, dark urine, etc., and the presence of target cells. Target cells are basically present because, like we said, anything to do with the membrane damage means that you may or may not see some amount of blebbing. And when there's a blebbing, centrally, you'd have something called the target cell. So this is not unique to sickle cell anemia, but it's definitely a sign. And lastly, because of the increased amount of hemolysis, you'd obviously have a response from the bone marrow, and that's when you'd have erythroid hyperplasia. Now, what's important in these patients is that the hyperplasia then becomes extramedullary, and that means that it not just stays in the long bones, but it also goes into the flat bones, which include the skull bones, giving the patient a crew cut appearance, and to the facial bones, giving the patient a chipmunk face, especially on the X-ray. And obviously, because of extramedullary hematopoiesis, what ends up happening is that these RBCs, are not made with the same integrity that the long bones make it with. As a result, there is increased hepatomegaly, because we know that there's hepatosplenomegaly because the macrophages in these reticular endothelial system become larger as they become overactive. And lastly, you have the risk of aplastic crisis, again because you basically shift the production of other kinds of immune cells. You replace all of that with just erythroid cells, and as a result, you have aplastic crisis. What's important to remember here is the parvovirus B19. And the second sign is when you have irreversible sickling. So in the later stages of these diseases, you should be able to see vasoocclusion. Now, In children, you should be able to see two very important things, right? So that you'd be able to see dactylitis and you should be able to see infection. Dactylitis means that there's end organ infarction of the bones of the hands and feet causing swelling. And so classically the child would present with these symptoms of a swollen hand and swollen feet. And another thing that can happen is because of the infarction of the spleen, you can have autosplenectomy. Eventually, it just kind of involutes and dies. That means that you would have an increased risk of infection from encapsulated organisms. So in children, you have increased infection from Haemophilus influenza and strep pneumonia, and this can be a cause of death as well in these children. And it's the main cause of death in children especially. And in adults, you have Salmonella typhi. And this is another very important organism to remember. So Salmonella typhi, and it causes osteomyelitis in adults and pneumonia in children. Acute chest means that there's basically infarction of the lung, and the patient presents with signs and symptoms of pneumonia, which include shortness of breath, coughing, stridor, etc. Pain crisis, which basically means that the patient would have increased amount of pain that comes especially when the patient is under stress. We didn't talk about this, but deoxygenation basically happens during certain other disorders as well, and that could be hypoxemia, dehydration, or acidosis. These are stresses to the body which decrease the oxygen carrying capacity of the blood, and therefore they would be exposed to deoxygenation, which would cause them to polymerize. Pain crisis, and finally renal papillary necrosis, again end organ ischemia of the kidney, and this would present with hematuria and also some amount of loss of proteins as well. It could lead to permanent kidney damage. So again, looking at this diagram, we can see that when the person has sickle cell disease, you have an oxidant stress, which could be, like I said, hypoxemia, acidosis, dehydration. The hemoglobin S would undergo sickling, which would cause the RBC cell shape and size to change. And basically what happens with that is you'd have hemolysis, you'd have splenic autoinfarcts from the vasoocclusion, as well as the osteomyelitis because of autosplenectomy. And a more acute version of this would be the vasoocclusive crisis, which could present with priapism, acute chest pain, and avascular necrosis of the bone. So for the diagnosis of each one of these, you can just use DEXA scans for this one. As for the treatment for just about everything else, for hemolysis, you replace folate, iron, and hydroxyurea. For splenic autoinfarcts, you can use vaccinations and whatever to make sure that you can prevent the death of these children from Haemophilus influenza or strep. You can also give them antibiotics prophylactically. And in the case of vaso-occlusive crisis, giving them IVF, O2, and analgesia would be very important because the pain crisis, as well as acute chest, would be treated with that. With priapism and acute chest, exchange transfusions might be the best option. Again, pain, analgesia, avascular necrosis, maybe do a DEXA scan, and just increasing the amount of oxygen and IVF might just help. And now we talk about sickle cell trait. Now, it'll make a lot more sense why we spoke about the 2 beta chains when we talk about the sickle cell trait. But in the sickle cell trait, what happens is the patient has one normal beta producing chain and one abnormal one, which means that the patient would then have regular hemoglobin A and also diseased hemoglobin S. But because of reasons that we don't really fully understand, there's somehow more amount of hemoglobin A than S, and therefore they would actually present with no symptoms. except in the renal medulla. Maybe there's an increased amount of stress here, we really don't know, but the cells sickle. And when they do, they cause microinfarcts, microscopic hematuria, and then eventually kidney disease, and this can take a few years to develop. The lab findings, again, on the blood smear, you should be able to see sickle cell and target cell in sickle cell disease, but not in sickle cell trait. And instead, what we can use is metabisulfite screen. This causes all the hemoglobin S cells to sickle. So therefore, it's positive in both, and this is a much better diagnostic tool than just a blood smear. Electrophoresis can be used as well. So electrophoresis, basically, depending upon the weight of the proteins, can distinguish them, can put them on a different spectrum, which means that you should be able to quantify the amount of hemoglobin S. And that's important as well, because obviously if you have more amount of hemoglobin S, you're more likely to have sickle cell disease, and then less than would be sickle cell trait. Obviously, some amount of genetic testing, looking at the family history, some other present problems can help you diagnose this disease as well. So treatment, hydroxyurea, because it increases the hemoglobin F. To prevent the stressors, regular hydration, all of that would definitely help. Hemoglobin C. Hemoglobin C is a very, very rare disorder where there's a mutation in the beta chain of hemoglobin B. Instead of glutamic acid and valine, now you have glutamic acid being replaced by lysine. So basically, the patient would have defective hemoglobin. As a result, they have mild anemia, and this is because of extravascular hemolysis. And the characteristic hemoglobin C crystal. Talk about normocytic anemias with predominant intravascular hemolysis. First one is paroxysmal nocturnal hemoglobinuria, which basically means that you have hemoglobinuria or hemoglobin in your urine at night. So this is an acquired myeloid stem cell defect, and basically there is a defect in the PIGA gene. And what that means is basically the RBCs would not have a GPI anchor. You have an RBC flowing through the blood vessel, and you have quite a few complements around it that are just running around it all the time, ready to be fixated to the RBC. If it does get fixated to the RBC, it causes extravascular or intravascular hemolysis. In order to avoid that, you have these factors like DAF, which is decay accelerating factors, bound to the cell membrane by GPI anchor. And this would basically inhibit complement fixation. But if you have a defect in PIGA gene and then you have a defect in the GPI anchor, which means that the DAF is not able to bind to the RBC, that means that complement fixation cannot be inhibited any further. And this is precipitated in terms of stress, like hypoxia. And physiologically, we have hypoxia when we sleep because we end up breathing more slowly and we have shallow breathing. As a result, you have a slight increase in the PCO2, but this is physiological, and normally in a healthy person, we can compensate for it, but in these patients, they can't. And this mild respiratory acidosis is enough to cause all the myelogenous cells, which include RBCs, leukocytes, as well as platelets, to lyse. So in the morning when they wake up, they have hemosideruria and hematuria. And this is because of intravascular hemolysis. So these are the symptoms that you can see in this patient. So the diagnosis would be sucrose test, where basically you introduce sucrose to their blood, and sucrose causes activation of the complement, and that would cause fixation. Or acidified serum test, which again is just to activate it. And flow cytometry is the one that we use more likely, just to see if there's to detect the lack of CD55, which is the marker for DAF. Clinical features are hemosideruria, low haptoglobin, but low haptoglobin obviously can be seen way later. All of these are signs of intravascular hemolysis. And the most important thing is hematuria on waking up. And the reason for death in these patients is thrombosis. When there's breaking of or lysing of platelets inside the blood vessels, you have platelet fragments, which can induce thrombosis. thrombogenesis. As a result, you have thrombosis of the hepatic, portal, cerebral veins, which can cause pain and sometimes even be fatal because of stroke or some kind of end organ ischemia. The complications are iron deficiency anemia, obviously, because you end up losing a lot of blood in the morning, and when you lose blood, you lose hemoglobin, and hemoglobin is made from iron, so iron deficiency anemia, and AML, because you now have one defect, one mutation in the myelogenous stem cell. AML is just another one, and it's more likely to happen. And the treatment for this is you can just use an antibody drug, which is eculizumab. It's a monoclonal antibody. Next, we talk about glucose 6-phosphate dehydrogenase deficiency. This is an X-linked recessive disorder which causes a reduced half-life of G6PD, which then increases the oxidative stress. Now, you have to understand that the RBC is prone to being having oxidative stress, and there's a few mechanisms by which it is protected, and one of them is this. So, for example, if there was a stressor like H2O2, which is very likely to cause oxidative stress inside the blood, it can be broken down to water molecules using glutathione. So glutathione is this molecule that reduces H2O2, but in order for this to be present and also to be reused, you need to have G6PD. If you have reduced G6PD, you then have reduced glutathione reductase, which means that you won't be able to recycle glutathione, and therefore you'd increase the amount of H2O2, increasing the amount of oxidative stress, and that's how you would have the disease. So low G6PD, low NADPH, low reduced glutathione, and therefore you'd have oxidative injury by H2O2 and intravascular hemolysis. You have two variants, and both of these seem to be protective against malaria. You have the African variant with a mildly reduced half-life, which means that under mild to moderate oxidative stress, you wouldn't really see symptoms. Mediterranean variant, which is much worse, and you can see a markedly reduced half-life. Now, what can you see on a smear? So oxidative stress precipitates hemoglobin as Heinz bodies and RBCs. What that means is usually you have an RBC and you should be able to have a homogeneous structure on the inside, but sometimes you'll find an aggregate of hemoglobin inside the cell, and this is what we call Heinz bodies. And sometimes the macrophages of the spleen will kind of remove that, and what you're left with is a bite cell, and that's also something that you see on the smear. So some of the stress that can lead to increased amount of oxidative stress in the RBCs are drugs like dapsone and primaquine, infection, diabetic ketoacidosis, and foods like fava beans, especially in the Mediterranean regions. So Heinz bodies are removed from RBCs by splenic macrophages, and what you're left with is bite cells. Clinical features, all of those of intravascular hemolysis, so hemoglobinuria, and something that's unique is back pain on exposure to stress. Next, you have diagnosis. So like I said, Heinz preparation, you basically just take a smear with a Heinz stain and you should be able to see all these Heinz bodies. So if you look at this, then you know that it's, so this is kind of diagnostic, the presence of the Heinz body. Also, you can do just a simple G6PD enzyme study, but sometimes if you do it too soon after the first attack, it might be artificially normal, so you have to keep that in mind. And a simple way to remember this is the Greek man eating dapsone for breakfast, dapsone is a drug, primaquine for lunch, fava bean for dinner, and a bucket of sugar for dessert because of the diabetic ketoacidosis, might have G6PD deficiency. Next, we talk about immune hemolytic anemia. It's basically an antibody destruction of RBC. This can be warm or cold. The warm immune hemolytic anemia is basically when you have an IgG antibody, which is produced against RBCs in warm temperatures. So we call this a warm agglutinin. What this means is that there's an RBC, and for some reason you have an antibody that coats the membrane of the RBC, and therefore the spleen recognizes this as a foreign body. The macrophage comes in, and lyses the cell. So some of the reasons for this could be lupus, CLL, some drugs like penicillin, sulfa, rifampin, and methyl-dopa as well. So there's two mechanisms by which this can happen. The first one, like we discussed, is that you have the drug in the membrane, which is so you can have the drug which can bind to the membrane, and then your body would then produce an antibody against this, thinking that it's a foreign object, and this complex can be taken away by the macrophages. On the other hand, you can have the second option, which is the drug itself is identified as a foreign body, and therefore it produces an antibody, and this antibody can bind to the antigen of an RBC, and together this one can be removed by a macrophage. So the treatment is to stop drugs, to give IVIG. IVIG would basically just distract the spleen, because then the spleen would break down IVIG and forget about RBCs. Again, this is just a temporary treatment. Steroids and splenectomy if it gets really, really bad. Cold IgA, on the other hand, is IgM antibodies that bind RBCs and fixes complement at cold temperature, especially like the fingers and the toes. So in the periphery. And this is very important to remember that mycoplasma infections and infectious mononucleosis can precipitate this problem. So the treatment is obviously just to avoid the cold, to maybe give IVIG, steroids, and splenectomy is the same treatment. And the test for this, the diagnostic test, is Coombs test. A direct Coombs test confirms antibody-coated RBCs. So you're going to find out, your question is my RBC coated by antibodies? And for this, what you'll do is just introduce the patient's blood to an anti-IgG antibody. So something that would bind to this as well. If there's agglutination, it means that you had RBCs in the blood which already had antibodies, and therefore it's positive and the patient has warm IgA. Indirect means you're just confirming if there are in fact antibodies in the patient's serum. So what you would do is, so you would take the patient's serum, so which basically just has antibodies, and then you would take a test RBC, which is then along with anti-IgG antibodies. And if this agglutinates, then you have a positive test. On the smear, you should be able to see schistocytes, helmet cells, but they are not diagnostic. Then you have microangiopathic hemolytic anemia. This is basically intravascular hemolysis, not because of a problem with the RBCs themselves, but this is because of some kind of vascular pathology, some problem outside in the vessels. And this can happen because of microthrombi like TTP, HUS, DIC, or HE-LLB, which we'll discuss in a second. The first one that we have is TTP, or thrombotic thrombocytopenic purpura. It's basically a defect in Adams T13, which will basically increase the formation of clots and then cause damage in RBCs. And this can be associated with systemic lupus erythematosus. So you create a clot, and as you create a clot, the RBCs will kind of pass by it and they would lyse. On the other hand, you have HUS, or hemolytic uremic syndrome, which can be associated with the shigotoxin coming from E. coli, Shigella, or Salmonella. And what basically happens is there's an increase in von Willebrand factor, which would increase the formation of clots. And as you know, clots will cause lysis of RBCs. DIC is disseminated intravascular coagulation, which is basically just overactivation of the coagulation system. So there is increased amount of clot formation and increased bleeding. So if there's clotting, there's going to be lysing of the RBCs peripherally. And then you have HELP, which is seen in pregnant women. It's a hypertensive emergency where you have hemolysis, increased liver enzymes, and decreased platelets. Obviously, that's just going to cause increase in blood clots and decrease in platelets. As a result, you have lysis of RBCs. Other than that, you have prosthetic heart valves that can cause increased hemolysis, aortic stenosis as well. So clinical features, all that of intravascular hemolysis, which we know already, iron deficiency, anemia, again because of chronic hemolysis. Diagnosis on the smear, you should be able to see schistocytes. Again, that is not something that's unique to this, but the presence of this might definitely put microangiopathic hemolytic anemia on the differential. Schistocytes are helmet-shaped cells that kind of look like this. In a way, it looks like a broken RBC. Malaria. This is the last thing that we have to talk about. But basically, it's infection of the red blood cells and liver cells with Plasmodium, which is transmitted by the female Anopheles mosquito. So RBCs, when they get infected, they rupture as part of the life cycle. And when they rupture, they cause a fever, which is cyclical. And when they do, they cause intravascular hemolysis and like I mentioned, a fever. And this can cause so although it is mostly intravascular, it can also be slightly extravascular with a mild splenic hemolysis, which can result in increase in the size of the macrophages in the spleen, leading to a splenomegaly. And that is the end of the chapter of when we talk about normocytic anemia, with emphasis on predominant intravascular and extravascular hemolysis. I hope this made sense, and good luck with your exam.